So we are live.
Good evening. Welcome to iFocus lecture 51. This is by Professor Rohit Shetty, who is the Vice Chairman of Narayana Nethralaya. He is a new breed of ophthalmologist. Actually, he's a clinical and translational scientist as well. So basically, he does both clinical work and integrates it with basic sciences by doing translational work. And he finds solutions for vexing problems which are unique to India and his field of interest, which is cornea and refractive surgery. So he's possibly the most appropriate person to speak on what's new in cornea, which is the topic of his talk. As I said, he's a clinician scientist, and he mentors a large group of fellows who have enrolled into a dual academic program, which is a clinical fellowship combined with PhD in Maastricht University. As expected, he has huge number of publications in peer-reviewed journals, and he's on the editorial board of Journal of Refractive Surgery and fortunately on IGO as well. He has keen interest in ectatic disorders of the cornea, inflammation and apoptosis pathways, which lead to pathophysiology of several corneal disorders and laser refractive surgeries. He has received the Colonel Rangachari Award in 2015. These are some of the few awards that I'm naming. Otherwise, his list of awards is stupendous. AAO Achievement Award and the prestigious Casimir Award by ISRS. The latest feat of Rohit is this big issue of IGO that he actually spearheaded. You know, it's a 472-page IGO, which is the biggest possibly of any of the ophthalmic journals in the recent past. Has everything on refractive surgery and possibly going to be the Bible of refractive surgery for some years to come. Thank you, Rohit, for spearheading this. So I stop share and request Rohit to start his screen share. Ankita, you wanted to tell a story about Rohit? Not now?
At the end also I can say, sir.
Okay, fine. All right.
Thank you, sir, and thanks to your team for wonderfully crafting this program. I've been watching some of them. I've been asking my fellows also to watch a few of your fellows and PhD students. Recent advances in cornea is what I'm going to speak today. These are my financial interests. I'm sure that I'll be talking about a lot of technologies and tools, but I'll be careful enough not to have any impact because of my research, academic, or any relationship with these companies. The talk for cornea and refractive is I went through your program, and the next few programs till December end or early Jan is filled with very eminent cornea specialists, starting with SK Rao or Dr. Sayan Basu at the end, and Dr. Himamshu also on dry eye. So I'm not going to go into the depth of every disease. I'm sure that is not my idea here. But I would bring in the concept of more than teaching. I would like to inspire people, youngsters who would be interested in looking at cornea from now on. You know, I mean, each one of you would be keen on picking up your specialities, and this would probably give you an insight into this. This is definitely not a postgraduate writing material, what I'm going to speak. But of course, you can pick here and there whatever is whatever applicable to you. So let's start with imaging. I think there's in the branch of retina, it's a hugely image-driven one, but you have one OCT, one fundus fluorescent angiography, or different things. But here is one place where you are looking at imaging every layer by layer, and that is something which is very exciting about cornea. I think each layer has different ways to image, different age way of imaging. I mean, I don't think we in retina we come to state that RP itself has an imaging OCT, or you have a different layers of OCTs. I mean, that is the real big advantage of this. We started with keratometers, autorefractometers is a big thing, and then placidos, OpScan, the pentacams, and many of these scans keeps coming. I'm not going to do depth of imaging of a topography because that itself would take an hour. You look at different maps here. You have the OpScan has its different map, the Galilei, Cirrus, all of them have their different individual signatures. Each one is based on a placidos or a non-placido based systems. And the real change came in use of Scheimpflug imaging, which looks at the corneal, both the scans as well as you get some pictures of your A scans and you have your imaging of your lenses. For people who are interested, I think, and Dr. Santosh Anubhav sir had given us a great opportunity, and he had beautiful set of articles out it, and it's all free. So one of the reasons I'm not going to depth of it, because I want you to have the pleasure of downloading them and reading them. That's a homework for all of you. And we have had all the scans given for the latest. That means what is there in 2020. So you don't even need to worry about, is this an outdated material? And this is written by best of people. And all the map readings and what this each map does and what each indices does has been beautifully covered. Like I said, the idea here is to give you an insight into it, and so that you go back and read, and you just go to the website and you'll get them all in a PDF. And what is important in cornea now is, like I said, let me go layer by layer. You start looking at, earlier we were only looking at the whole stroma. Now you measure the epithelium. This is the stroma, and that's the beauty of it. It's like measuring the retinal pigment epithelium and then the nuclear layers and lamella, all those layers. And imagine we are able to measure each layer of cornea and see, and the thickness, the elevation, the aberrations. And that is what the real power. A small change on the epithelium here is picked up, and that is matched to your stroma. That means it virtually subtracts the whole thing. This is without your epithelium. So what is happening is the corneal imaging is taking a very big shape. Then comes the second one. There is no tissue in the human body. There's no structure on human body where you can measure both the imaging and also how much it can stretch. Imagine it's in the skin. You can, imagine you are mapping the skin, but you don't know how much does the skin stretch. And that's the only possible in cornea. The corvus is one of the measure where it looks at the deformation of your cornea. And these are all the maps. And if I play these videos, this is how a healthy cornea deforms, and this is how an abnormal cornea deforms. And you can see this is a keratoplastic cornea. You can see how much it deforms. The amount of deformation is huge compared to the amount of deformation here. So this itself is a huge impact into our understanding. And using this deformation, we're able to have a lot of mathematical jargon. And one of the things I never liked is mathematics, but virtually in cornea, everything becomes mathematics. So even though I don't know much about it, but it makes you to go back and study. And when you incorporate a mix of topography and your biomechanics, you get all these indices. These indices, which is there, and again, this is all given in the IGO journal, helps you to understand how the cornea is studied. Like, for example, you take a skin, the surface of the skin is given by your topography here. How much does it stretch is given by this, and this is what the cornea is. And that is where the power of this is. Various applications, ectasias, cross-linking. After you do a cross-linking, does it become tight or weaker, or is it getting weaker? And a huge, huge impact into understanding. Of course, this tomorrow is going to be part of your cataract surgery also. Now comes the second part of it. The second part of it is we looked at the epithelium, we looked at the stroma. Now we look at the imperfection in your optical system. That means from your tear film to your lenses. And these imperfections are called as abrometer. And there are a lot of abrometries today. iTrace is an abrometry, and there are different and textbooks have given you that it's a ray tracing, Hartmann-Shack, and each one of them have different ways of abrometer. So now what does it do is you have imperfection in your cornea, in your lens, and this is what goes to the brain. This is your total. So that means you can dissociate. The power of corneal imaging today is the power in dissociating it. And you can see that the quality of vision provided, if you have only cornea, what does the quality of vision do? What does the lens do? And what actually goes to your brain? And in the brain, it gets neurally filtered. So all this is possible in the today's technology. And these are all the aberration maps, which again has been clearly explained. This is beautiful accommodation. All our life, we have studied how does the lens accommodate. You can see that this is a healthy accommodation, this is unhealthy accommodation. And you can see that you're accommodating more. When you're stressed, your lens comes forward. When it's red, it means that you're accommodating at such a state that suddenly you become myopic. And when you're calm, like I see Dr. Santosh Annawat, I think this is how he accommodates, even at this age. Pleasant blue green, absolutely. Only it gets red only when it's necessary. At that point, when you're reading a small letter on your news, and this is some of us when we are really stressed, tremendous amount of strain. And this power of accommodation was never known. There is a beautiful relationship between uh, lens and the cornea, and that is the power of understanding the corneal and the lens accommodation. The beauty is that in the cornea, now we are able to look at the tear film. Tear film has always been called the phantoms of your vision. The phantoms of your vision is that it's a ghost you don't see, but it exists. And what is important is now you're able to image them. This is your tear film of a normal person, healthy tear film from your blink to the last blink. You do a perfect surgery and the patient is not happy because your blink to the last blink, the tear film is changing. And look at the tear film from the first to the last. And this C to this, and this is perfect. So imaging the cornea starts with also the imaging with your tear film. There are a lot of new technologies to look at virtually everything, your myographies. You don't even need to put your stain into the eyes. Take the patient to one of the machine, it gives you a non-contact tear film, T-bud, and you don't even need to mess up the stains at all. And you can look at your tear film, you can see the quality of lipid layer, compare it with what kind of a lipid layer you have. And you can even measure the tear meniscus, and it comes automatically, and it's making you just sit down. And, I mean, of course, there are issues with the repeatability, but that's going to change over time. And of course, the meibomian glands are very important, and the way the meibomian glands are structured, you can see these are meibomian glands, and you can see these are healthy. You can see there's a dropout here, dropout here, dropout here, and you can see a huge amount of dropout. So you can actually grade it, and all this has a huge impact to the quality of your tear film. And the lipid layer virtually has we mentioned it as a lipid layer, and this is given by the quality of the lipid. It's like oil on water. A good oil on water is good, and you can see that this is poor. Just means that your quality of lipids is not great. And this coming to my favorite one of the tools, I've been using this as a prototype for the last 14, 15 years of the confocal microscopy to study what the corneal nerves were. And you can see that these are the corneal nerves. These are your Langerhans cells. You must have read about Langerhans cells, and then they become, when they want to fight against an infection, they become dendritic cells. These are this is one of our own discoveries. We've been working a lot microneuromas. If you have one, the patient complains of neuropathic pain, and whatever you do, they just never go off. And we build imaging software which helps to look at the nerve parameters on the ocular surface. And a lot of papers published by our group and our team about how the nerves change with vitamin D and all of them. And that point of time, we were one of the first to bring out the concept that vitamin D is necessary to fight against inflammation. And these inflammatory cells were related to the vitamin D. And for many years, people kept telling everybody has a deficiency. Why should some only fun people do? It's just about the genetic predominance. You may have a deficiency, but everybody may not manifest. Unfortunately, the COVID got in a new angle. Now we know that if the vitamin D is low, your body does not fight. That means dendrite, all these cells are at very, very low potential to fight. And that is why the vitamin D and the ocular surface is very important. So we have to understand that this has a huge impact in our health of the nerves. That is what we need to undo. And like how you say in the old times, carrots and all that has a role in the retina. Vitamin D has a very important role in the ocular surface. There are a lot of new therapeutics coming out to treat. These are all new age therapeutic for the dry eyes. All this Slippy Flows, Eyelight, and all of them work on different principles. They're all intense pulse lights, which helps to stimulate your meibomian glands and bring down and plays an anti-inflammatory role. So is Slippy Flow. I'm sure Dr. Himanshu is going to speak about it in the next few sections over time, but they all have an impact on the quality of vision. For all postgraduates, it's important to read this, and it is very important, and you get it very freely. You write Deus 2 on Google, you get this picture. So I'm not going to spend too much of time. Self-explanatory picture, how you divide dry eye, and everybody has to write this in your exam because you have to know it. Even if you write half of it, you'll get it. And this nociceptive pain has to be mentioned because this is the new one. Symptoms without signs is a new classification. And this will be asked in Viva, what is new in Deus 2? Because it keeps adding Deus 1, 2. So this is new in Deus 2, and this is what every cornea surgeon should know, because you can have pain without having any of this problem. And again, this is again mentioned very beautifully in the TFOS DOS. This is all freely available, freely accessible. If you go to TFOS, Tear Film Society, you can access this easily and you will get it. If you don't want to do all that and you want to have, again, thanks to Dr. Honavar sir and the team of uh, uh, of authors, we are able to bring this all out in a beautiful concept. It's called Algorithmic Approach to Dry Eye. It's a post-refractive, but it's all the same. How it is divided into different types of dry eye. It's a way the new classification is. And every cornea surgeon, every person who wants to do has to do it, has to learn about it, how the basal nerves change. I just mentioned about it, goblet cells and all altered changes, and how it all changes is all given here. That's why Dr. Sir Honavar sir mentioned about this paper, is because everything what you need for a practical point of view is here. So I request all of you to just go down and uh, just click on this and download it. Yes, I have a lot of financial interest in this. Dr. Honavar sir is going to give me a lot of money every time you download these articles. So everything is beautifully done, and everything has clearly explain about how do you evaluate it. This is not there even in the Deus 2 in a beautiful way. When we started reading this, we wanted a postgraduate to practice and also write an exam. If we just look at each and everything, and we went to a lot of brainstorming session to build this article, this particular article, and how do you manage it? It is just not about just write something else. What inflammatory molecules are giving? When you do a punctal flux, when you treat it, it's very beautifully written. And you don't need to look for anything else. It's all given out here. So what are the future refractive surgery? I come to the refractive surgery. There are different types of refractive surgery. Again, there is talks on that. PRK is one of the first where you don't cut the corneas. It's now it's a trans PRK. What is the advancement? That means that you don't need to remove the epithelium. The laser takes care of everything. Two main machines. Fortunately, I work on both the machines, the different profiling systems, but basically the machine takes care of the uh, of the uh, of the lasers. A lot of confusing terminologies about wavefront optimized, wavefront guided. This is all important for a refractive surgeon perspective. Basically, it's about how the laser is given on a cornea. Webtin optimizes, it gives you in a very optimized way, and that is what Contura is. Basically, it takes your topography and feeds into the laser, and the laser gives you a very beautiful way of giving laser, and that's what it does. Because it takes in much more factors than what it normally does. So this is what happens. Basically, you get a better form of laser and a better outcome, and you end up in a better healing. Wavefront guided is you take the whole cornea. Wavefront topo guided is only the cornea. This is from it even takes in the tear film, the cornea, and the lens, and the retina, and everything is incorporated in this plane, and you treat whole. So there are advantages and disadvantages of both, but this much you had to know, that is a wavefront guided. It means that it takes in the whole of the eye, the cornea, the lens, and the whatever is called. So that is what is important about this. Of course, there's a lot of talks on smile. There's a small video about how smile is done. Is one of the future of refractive surgery. What it does is, once you build a suction, and there is the cut is, this is your lenticule is made, and then you make a cap. This is a cap, and then you have an incision here. We just open this up, and it's a very go both ways. You dissect the lenticules, and once you dissect it out, and you just have to take the lenticule out, and that's over. The surgery is done. This is how the surgery is done. There are different ways to work on the cornea. Again, this paper is there on the thing. You can look at, you can laser the cornea to get you a perfect blend zone for the correction of presbyopia. There are a lot of even doctors who got it done. So, you can, this is how you write an exam. Basically, every single article we have put on this group on this particular issue is all about how a postgraduate should write, and also it should be practically used for the people. And Presby bond is something which you hear late, where everybody is from Zeiss. It creates a blend zone where it's not a monovision. It uses the aberrations of the eye to create a blend zone which gives you a perfect depth of focus. And cornea is all about imaging. In keratoconus, the first thing which has changed is the classification of keratoconus. Again, you can go back and go to this. The classification of keratoconus, Amsler's, grade, what your Kansky gives is completely outdated. You have to write about ABCD classification. ABCD comes from the Bellin's classification, where it talks about these are all the parameters from your topography, and uses more of a topography based classification. And you can see that how he classifies it, and it's all inbuilt in the machine. Once you add everything, the machine itself will give you the classification. So this classification has a huge strength than the current conventional one. Again, management of keratoconus, we have a beautiful article again in IGO, which looks at what are the high risk characteristics of this, what the scoring system, the first to build a scoring system. I'm happy that it got published 3-4 years back in this. It was one of my, with my PhD guy, Dr. Rudy Nojits, who is the present ESCRS president, and beautifully formatted about how do you manage a keratoconus. It's been used extensively now about in the corneal plan. And there are different ways of even how do you give the lasers. Again, this was a issue which we did on special issue on keratoconus like what we have now. So I put a lot of IGO articles because it's easy for you to download and easy to read, and it's all made for the format for a postgraduate writing. So these are intact planes where you put a ring inside the cornea. This is not outdated, which still I feel has a huge role. And this is a planning which we did again, which is there in the IGO. A few things into the corneal plane, even though I don't practice this often. There are people in my team do a wonderful job, and there are a lot of very good articles again on this. There are lamellar keratoplasties, especially today. That is the in thing. You can take care of the stroma. You take care of the stroma, treat it with the stromal thing. If it's endothelium, treat the endothelium, because that is what you need to treat. And again, it's for MyGeo, and they have your advantages or disadvantages of each. TMAC, you're not taking a thicker version of your endothelium and desmids. You're going very, very and very, very thin, so that your refractive outcome is much better. You can see that in this paper, this is the amount, and here you hardly see anything. So your refractive change is very minimal, and it's a more tougher procedures. And PDEC is from the both Dr. Dua and Dr. Amar Agrawal's group, which they have published their work on this. Limbal stem cells, a lot of changes happening. There is a talk by Dr. Sayan, I think, end of next 2 months. I'm not going to because I'm sure he's going to talk about it. But what I'm going to say is this paper is very important. So my talk today was more about introducing you to reading papers. I'm sure that all of us like to have notes, but what happens is when you don't read articles and journals, you just get notes from a different perspective. If I make a good note, it is for my perspective, for my just to pass an exam or whatever. But I don't get inspired about the work, nor I get to know about how it's written, nor I know about how a simple paper is written. That is one of the reasons why a lot of postgraduates hardly publish their thesis, because they are just not reading the real articles. They just pick up the notes. But I request all of you to read it, because especially this, Dr. Sangwan is in this group, and proud to have, and there are a lot of very beautiful references about etiology of LSCD on the corneal plane, what really causes this. These are all extremely new articles, including the classification also is very new. So all this has to be looked at. And again, this global consensus where Dr. Sangwan is there is published in Cornea, and you can see that how they would manage it, how with comorbidities, without comorbidities, how do you manage it? And this is what you need to write in your exam. How do you take care of your ocular surface? Basically, most important thing again is the tear film and inflammatory, and they're all given in a very nice format. And you also have some images, the different type of autologous limbal transplantation, conjunctival limbal autografts. I'm sure all this will be discussed. I'm not going too deep into a cultivator. I used to cultivate them in your lab and then transplant it. Now, not much of this is not the present one in vogue. And what is really for very severe ones, you're looking at bilateral ones, you're looking at culture, ocular mucous epithelial cell transplantation, and created a Louis Prasad team with Sayan and Dr. Sayan and Virendra Sangwan sir has created a beautiful concept of SLED, which I'm sure you'll hear it from the best person in the country. So I'm not going to go into this, but what I'm trying to say is that these things are what you need to be aware of when you're talking about the modern day changes. I'm going to go into a little bit in the research, the last 5 to 10 minutes of my talk. This is what I work on. Like I said, I work on epithelial cells in my lab, and this is what a human epithelial cells look at. All our life, you have seen that, we write about Golgi bodies, endoplasmic reticulum. I never thought one day I would actually see all of them here. And this is one single cell. And you can see all of the cell organelles, beautifully cell organized, mitochondrial, everything is there. This is what happens in a healthy status. And just take this off. And you can see that this is what he's mentioned about this, and these are all your mitochondrial lysyl, all those cellular things. And this is the cellular transport, beautiful cells, how cell to cell transport happens. And you can see all that stretching. This is all epithelial cells, not on the human ones. This is the one which we grow in the lab. And you can see how this is moving. Just for a second, see the beauty of human each cell to cell changes. And what happens is when you have a lot of stress, when we talk about dry eye, look at the concept. There's no cells at all. The cellular function is gone. And these cellular functions are gone because look at this. Look at this, the healthy, happy, joyous, joyful cells. And look at this unhappy, really stressful, angry cells trying to survive, to breathe. And this is exactly what you see when you're wearing a mask for a long time, because a lot of us are going to a lot of ocular surface changes. So what is new in cornea today is bringing in new drugs. You have to bring in new drugs because you have to understand the cells are not responding to same thing to what you used to do. This is exactly what Dr. Santosh Honavar sir and his team would be probably doing, that your retinoblastoma or any of your ocular tumor cells don't respond to what it was responding 10, 20 years back. But corneal drugs have not changed. The same dry eye drops still continue, the same thing continues. That's why none of our patients are getting better. So what we did personally is build a lot of work around bringing in new drugs. That has been one of our areas of work, and I'm happy that that one of the drugs did win. The Trehalose was one of my PhD student, Dr. Natasha's Rangachari paper. I'm happy that there's one of those papers which won the Rangachari and also went on to become a commercial. We unfortunately have no commercial interest with that. It's just that we did the scientific work, and now lots of company are using. And in during the Trehalose time, this is one of the most used drug because of this. And it's not only that, even in many countries across the world, this was published during the COVID time. Trehalose actually has an ACE2 inhibitor block. You can see the effect of Trehalose working on the epithelial cells. There's a paper which we are writing up now about what we took the eyes of cadaver eyes, and we can't end any talk today without COVID. So I just want to go a little bit into COVID, and we dissected layer by layer, and we compared the amount of ACE2 and the COVID-related receptors in the eye from the epithelium onwards to the retinal epithelial layer. We were surprised that after, I think, lungs, the eye has, and we dissected close to 7 or 8 eyes. Uh, we could have done more, but there was no real, but we are not getting the eyes for dissection. And we found that at least the second highest number of receptors which the COVID can attach was in the eye compared to published report in the lungs, after lungs. That means there is a route of entry. Why they're not entering, whether they're entering from there, what they're doing, we don't know. But we all have to understand that eye is also potentially easy route. So that point of time, even now we practice, and for healthcare high risk workers, we tell them to use these drops, and it's known in other branches that it works against Zika virus also. So what I'm trying to say is there are a lot of new drugs which are coming in. A lot of new drugs on the corneal plane works on a very, very sensitive immunological response. So it is important. For example, tomorrow one of the companies will come. This is Zedra, okay, and people say, okay, use the Zedra, and you don't know what is Zedra because it is lifting-grass. And every new drug has to go through this space. Always, this is why I put this. Always remember this. These cells and how they act when you put a new drug, it will all take at least incubation time of 4 to 5 years to come out with one concept. And if you look at some of these papers of ours, it must be probably 2013, 14, or even later than. These are all the papers published by our team. And somebody would come and say, when you look at this is important. I mean, for somebody who's interested, you can take a screenshot of it. This is an efferent arm and efferent arm, and what molecules you're bringing in. All these are cytokines molecules. These molecules are desiccation. Desiccation is nothing but stress. Even mask causes desiccation. When you wear mask, there's hypercapnia and your cornea can get dry, and all these inflammatory molecules can go up. So eventually, if you're wearing masks for a long time, a lot of diseases of your ocular surface. When I'm also talking to Dr. Anawar sir and his team, including your OSSN and a lot of NEVA and other things which are supposedly have to be benign, will flare up. Not today, maybe tomorrow or day after, because your entire this arm is being tremendously pumped by your long mask, which is creating change in your pH and creating a hypercapnia. And that is what I've been trying to work on, because we have been having a lot of samples of tears of people, healthy people, before COVID, and now we are trying to see what is changing. I'm sure this will change, because you can see here just the desiccation step, the amount of changes it's doing on the ocular surface. So please be aware, all of you, that we all have to look at ocular surface of any kind, including tumors, completely different from pre-COVID to present COVID, because there will be a complete different change. And when you see these new drugs, it will act on one of them. This is one of the molecules is going to act. And we will bring in the new molecules on the corneal plane, which is going to be the way forward. And one of them is this new drug which has come for neuropathic pain. So what you're going to see in cornea is a new wave of drugs. The old generation will be slowly, like how somebody asks you, do you write, of course, we still write chlorophenol, but somebody asks, do you still write a chlorophenol? Yes, sometimes, because we don't write that as a drop. Now, a lot of new drugs will completely slowly take over and start looking at it in a different way. And these drugs are all coming from the same arm of this. If somebody really wants to know, this is how it's done. If you understand this, then you know where to block, which drug will block, because it will have to block on one of them. Only then it works. So this is how a drug development is done, and this is how it works. And a lot of work has been on for people. This is one favorite exam question of Rho kinase inhibitors, which is helped in patients who have a poor endothelial cells. You use the drops. This was earliest work done by Shinigura and his team, and Japanese have been working on this to increase the endothelial cell growth by using this drug. And we've also been using, this is something which all postgraduates should be aware of, read about it, because this is always asked in your advancements, and this is something which is very useful in your plans. So what is really the future? I see the future is looking at collagen imaging. This is some of our work where we are imaging the collagen directly on a patient. This we work with the University of Vienna. It took 6 years to build it, and it looks quite bad, but it does the work because it's the world's first imaging of the collagen. You can see that. Look at this. There's no collagen here. Look at this. This is a healthy collagen. The structures, it's like pillars in the periphery. Centers are strong. So a lot of new areas of imaging is happening, and this is how the future. I showed you this image. The question we people always ask is, this is all great, but how do we check for this? How do you know this exists in my ocular field? How do you know this is there in my tear film? How do you know this is there in my tear film? So this is not like blood. You take a blood and get your test done. This is what has been working, and then this is what has been my passion also for the last 15 years, and this is what I got my PhD also, is to study the biomarkers from these tears, and this is what we do, and this is going to be the future. This is an ELISA based kit. You can take the tears and you can read it out, and you can just place it in one of the readers. This is on a beta testing now. This is in our clinics now. It takes an hour for me to get a lot of cytokines, and as we keep moving, I think more and more cytokines can be done. Dr. Anand also did his ROP, VEGF. Basically, this platform gives you a complete insight into the future of what we are going to do on the ocular surface. And this can be used for biomarkers. And there was an interesting thing. Once a newspaper article, a newspaper lady was asking me she was writing an article on this, what I just showed you. And she said, can you take my tears and tell me what it contains? I just took her tears, and there were like lots of stuff which was there. And some didn't make any sense then. That VEGF in her tears was very high. It didn't make any sense because VEGF was not supposed to be high, and she didn't have vascularization. Then I said it's just maybe a physiological variant. 2 years later, she asked me the same question. Many years back, you did my tears, and you said VEGF was normal and VEGF was high, but you said it was perfectly all right. So do you now? I want to tell you that I've been diagnosed with ovarian cancer. So no, GI cancer, somewhere in the GI tract. Do you think it makes any sense? Then I said, yes, it makes sense, because the Avastin was used for GI tract cancers, and Avastin does reduce VEGF. So probably high level of VEGF in the tears at that point of time was a biomarker for her, which we never understood. And I have at least two patients of mine where a lot of those inflammatory molecules, for different reasons I've analyzed, was very high. And a year, 2, 3 years, one lady after 3 years got to know that she has cancer somewhere else. So what I feel is ocular surface, cornea, and imaging the tears in the future would be a potential role for finding out even the cancer. There are people working on breast cancer and all that. The role of genetics, we were the first people to publish this new gene from a preserved lenticule, which I did not throw away. Throwing off things actually is like throwing off science, because this patient developed post-myelectasia 5 years back. 5 years later, I had the lenticule which I had taken up, the smile lenticule which and I had went back and checked the lenticule, and I found that she had a genetic defect of lysyl oxidase. This became the world's first paper, and we were able to now tell that, and this could probably be one of the factors to be identified for this. So what is the final thing in corneal thing is, like retina, cornea also has a lot of genetic related defects. You can also play around with the genes. You can also modify the genes. And all of you should always write that genes, genetic, and especially uh, Fuchs or macular dystrophy of the cornea or any of the corneal dystrophies, it can be in the future play a very important, if you know the identify the genes, play a very important role in gene therapy. This is a picture of how a gene therapy is. This is not a COVID ICU. In fact, we were used to, our team was used, the research team were used to a more stringent than the COVID ICU. So we had you can see them dressed like this because you're looking at a class 100 or class 50 rooms where you're making those virus. And this is one of the world's first pictures, and I'm happy that it's not on the patient, but we tried on the rabbits, and we tried to recreate a keratoconus model, and did. I mentioned that we found a gene. We're trying to work around whether you could plan a gene therapy for genetic disorders for like a keratoconus. And you can see this is a mouse, and this is all this we did during lockdown. And in fact, lockdown had us really worked harder, and we've injected the genes and modified the gene therapy. This was just a safety thing, and of course we are waiting. We need to do it on rabbits, multiple levels. But what I showed you here is it may work, it may not work. If it doesn't work, there may be something else which will work. I'm just saying that there is a lot of potential for these things. In summary, I know it was not a postgraduate writing exam, but like I said in the beginning, my disclaimer was very clear. This is just make you read so that you go back and read subjects. So it's about imaging, it's about new drugs, it's about new lasers which can correct you. Keratoconus management, you just have to go back and read those articles. Surgical outcomes, there are next few talks in your iFocus is going to be based on this. But at least if you know these things, that if you divide into lamellar keratoplasty and a posterior endothelial keratoplasty, which include DSEC, DMAC, this probably would be, then you can write on this. Last part was just to inspire you about the future direction which we're moving on, about targeted drug delivery system. And everything is about AI. And I'm sure Cornea is also going to be on the AI platform. I thank Dr. Honavar sir and the entire team for this wonderful opportunity to share some of our work with you all. Thank you.
Thank you so much, sir. It was like an eye-opener, and your researches were like astonishing movie we were watching. And I'm sure, sir, after today's lecture, everyone is going to open their mail and download all the interesting articles that you have mentioned during the course of the class. It was totally a 2020 lecture, and it has brought smile on all the faces. Before I take any questions, sir, I want to share a memory with you. You might not remember. Okay, it was way back in 2017, my first iFocus, and it was my first national lecture competition where I have participated ever. And in the background, I had you and Shetty sir as judges. I don't know if you remember or not, a girl who stood on the stage with a lollipop, and I explained anatomy of the eye without using any slides. And after this thing was over, you asked me if I have ever presented this before. And I told, sir, this is my first ever national presentation, and I know I don't have any slides. And you said that it was a very bold presentation at this platform. And that was the first time when I got my first lift and confidence that, yes, we can present anything in our own style. So thank you for that encouragement.
I think that's what I want to tell you from this platform is we are always worried about what people think about what we are doing. My entire work has always been ridiculed, and I see if I listened to all of them, I probably would have done not even 1% of what you did. I'm happy that you did that, and you took up what you interested in. And one of the good thing is I have a phenomenal, more than anything, I have a very photogenic memory. I remember you very well, and I also told you, if you don't remember, that why don't you take up Cornea also?
Yes, sir, I remember. I remember that.
And you said at this point of time, I remember the inverted commas. The words
Okay.
you said was, now I'm debating between cornea or oculoplasty.
I thought you forgot me, sir. Well, definitely you're an awesome person. Like the first interaction, first judge, I was really scared because everybody was like, okay, Shetty sir is there, Shetty sir is there. I was like, I don't know. I have to just present there.
I guess. Did she win, sir?
Oh, no, sir, I didn't win. In fact, I asked sir also, sir, my presentation was so weird. I didn't even have the slides.
Went on to win subsequently. Now she has a collection of iPads.
Anyway, I think we congratulate you also. I saw sir's mail. What I really liked about what sir said is that 6,000 square foot space is not a hindrance for research. I mean, I keep telling this, the barrier of research is not the money, it's your mind. And so I want all of you to remember this, that do not worry that I don't have a lab, I don't have this, I don't have an equipment. People keep worrying about it. That's why they don't move at all. And in fact, when you have more of all this, you become very, very lethargic, because you believe that the lab will fetch you everything, or the research people will fetch you everything. I think what Sir mentioned, I think this is for all postgraduate you're watching. He mentioned in his thing 6,000 square foot of space, and he did what he did. It is all in the mind, I'm sure, in the vision of what you want to do, and pick up what others have missed. And that is all I think is necessary. And the rest, everything, you can give it, you can get it in the books. Like I said, my talk today was not for the postgraduate to write exam, because everything you get it in the books. And today, thanks to Honavar sir, he was kind enough, he gave me thing, but everything I said he added. I said, sir, let's add 20 more of this. He added. I'm sure he would have to face a lot of questions from people to make it, but he didn't never, and he never made us feel that it's a burden. And this is every single paper I put is a paper for postgraduate. All you have to do is simple sit down, download it, and read it before exam. You get everything you want. So 6,000 square foot is not a barrier.
So not at all, and that too when sir is sitting behind. Even like, it's one time when we feel like, no, it's not possible, but he will make sure that we do whatever, he tries to take out the best from us. That's the best thing I think also.
Again, I'll tell you a story. Like I said, we are talking informal. There's no academic part. Uh, one of my, this was for the one of the conferences, the ASCRS. My fellows, I asked my fellow, when is the last date? She typed ASCRS. ASCRS also stands for some other gastro or something else. So they said that its date is postponed to some other day. So we all kept quiet. We were waiting for the next year. And suddenly somebody who was some smart fellow who actually went to the real ASCRS found that day night, 12 o'clock was the last. This was at 7:30 in the night. From 7:30 in the night till 12 o'clock, we submitted 48 abstracts, uh, 6 ICs, and something. Now tell me, we would have probably done the same if you had 1 month also. And I have put it on my wall, all the 48 abstracts with the 7 videos and everything. And I said, where did the energy come from? It's just that it is all there. It's just that we sometimes have that mind block, we'll have to have a 1 month time. Like Sir said, we need to have 20,000 square foot of lab to make a research. That doesn't need. So I told them, don't remove that. All the 48 abstract, it has to be on the wall, because it will remind us that if you want it, we can, in 2.5 hours, we can create 48 abstracts.
That's an amazing, sir. Rohit, sir, one more thing, just apart from all these things, your videos are amazing. Amazing means literally amazing. Before, like, I start working on any video, I always go to NN site and look at your videos. Okay, it has those mirchis, masala, Indian side, those delicacies, everything is there. So how you come up with the videos ideas? Like when you make a video, how you do that?
See, one of the things about video, when you're making a video, is it has to be not copied from anywhere. Nobody has, see, novelty brings in interest. If you start a video, and I always tell, when you make a video, the first 30 seconds will decide whether somebody is going to watch a video or not for the next 3 minutes. And the last 30 seconds makes you decide whether you win or not. So there are only 60 seconds of video, which is very important. 30 seconds for somebody to watch, and 30 seconds whether you want to win. So people miss the whole thing completely. They make the middle part so beautiful. The first 30 seconds is filled with all kinds of crap, and the last 30 seconds is filled with everything. So most important thing in a video is, remember this, that how do you make that? So I put all my efforts into the first 30 and the last 30. In the middle part anyway follows the trend. And second is, always use a template which you have never repeated, and go back and look at all the people who are big videos, and don't repeat the same template, and don't repeat the same music. In fact, in the past, we have used some of our own musicians, our own fellows who can play some music, to play the music and put it, so that it becomes even more it creates a bond. And video making is actually done quickly, but you're taking in people start with video and start thinking about it, how to write a script. We take at least 1 month for a script, and then finally they say that the Turkish proverb is there: you cut in your mind 100 times and cut once in reality. So people do the other things. They start cutting everything in reality, and then suddenly decide that you are going nowhere.
Very nice. It was like taking points. Okay, I think I'll go ahead with the questions, sir, from the different platforms. The first question is, what is mushroom keratoplasty, sir?
See, mushroom keratoplasty is what you do when you are using a laser. So when you do a laser-based keratoplasty, you can program the machine in such a way that you create a mushroom type of thing, so that when you have a mushroom, that means you're taking more of stroma and less of endothelium. So your endothelium part is less, but your stroma is more. That can only be done manually. People have tried. That can only be done with a laser. That means you program the laser. That means it takes like this, and then a small part of a stroma. The same thing is done on a donor, and you place it and you suture it. Supposedly very effective, but the disadvantage is the cost to the patient, because you're going to charge for the laser also, which comes with the price.
Okay, sir. The second is, what is bioengineered cornea?
See, bioengineered cornea is what happens is you are trying to recreate the corneal cells, and there are a lot of cellular 3D printing today, where you add everything, and the cell, like how you have a 3D printing. When you have a 3D printing, you can put everything and you get a printout. So there are cellular, that means you add particular cells, you add particular stroma, you add particular gel, you add particular matrix to that, and you create a 3D printing corneas. And when you add all of them, the 3D printer actually creates that change, and you bring in a cornea which gives the feel of a cornea, which feels of it. They've tried it in England, and of course, they've not really implanted it on a human eye, so we don't have a long data on it. But this is the concept of the bioengineered cornea.
Okay, sir. The next is, what are the recent advances in the preservative media for better graft outcomes?
See, I think it itself is a different topic. We started with MK medium, with glycerine, then we have a lot of new medium today. The best way to do is probably, I think there are some keratoplasty talks in this next few sessions. You can ask them to include that, because it would be probably better if you use slides to explain to this about medium, what it contains. Basically, that's what you need to know. And what is a real strong medium, and what does it do on the cornea, and how long it can be preserved.
Okay, sir. What is your take on trioptics, like transepithelial topo-guided photorefractive keratectomy for higher order aberration in keratoconus patients, sir?
That is, I don't know about the word trioptics, because it's called topo-guided treatment. It's called TCAT. So topo-guided treatment for ablation, where you treat the corneal, we take the topography is irregular, take the thing, and then you alter the shape. This is what it does.
Okay, sir. One of the postgraduate is asking how to choose and know which article to read for the new advances in general, if we want to read about a new topic.
Have an open mind. Don't go by what others say. Just open up. Just take up IGO. And because I personally feel IGO articles are written a lot with postgraduates and people in mind. Look at the current reviews. Look at there are a lot of sections on it. The preferred practice is one. I think a lot of specialty issues have it, including our specialty issues. Look at the preferred practice. Look at the special issues, like keratoconus was a special issue. I think Dr. Geetansha made one on cataract as a special issue, and we have come on refractive surgery. Pick up that, and if you don't want to read the papers, just pick up the preferred practice and the special preferred practice and current opinions. I mean, those are all the headings, and those will be more like a review, and that will be very current review.
Okay, sir. And about the new drugs which you have enlisted, sir, is it easily available in India, or we have to wait and?
Inhibitors, yes. I think Ajanta is making it. And I think that is something which is available. And the lifty grass is coming available. Yes, it will be available shortly. Then cyclosporin drops, yes, from FTC. UVLube is a drop, and Trehalose, I think all companies make it. Trehalube, Soha Tears,
Hmm.
Soha Liquigen, and all of them.
Sir, how is Trehalose so helpful in the case where we have in the cases which have progressed to corneal scarring or severe inflammation?
Severe inflammation, it may not have a role, but see, Trehalose and all these products are autophagy driving drugs. And what is autophagy? In the cornea, I showed you those cells which are under stress. Those cells die. So what happens when the cells die? You need somebody to take those cells off. It's like a housekeeping. Autophagy is a mechanism of cell housekeeping where one cell dies, the other cells engulfs it, and it kills it and it cleans it. That is how the cell death mechanism is. Like that means whatever is released from the cells is engulfed and cleaned. So when autophagy is dysfunctional, what happens is this cleaning mechanism is not there. So what happens when the cleaning mechanism not there? You just like, imagine your dinner plates at the end of the day stacked together and multiple things. So what happens? It creates tremendous amount of nuisance. So autophagy is when you put in these drugs, they induce some genetic thing where the cells are forced to do this cleaning. So that is what it does. So autophagy dysfunction happens in a lot, including your retinoblastomas and all your tumors. All tumors are because of poor induced autophagy. So what happens is in scarring, there are a lot of changes in your ocular surface. And these scarring in the ocular surface needs to be cleaned. So there is one area. Early changes can be prevented. Inflammation can be prevented. A lot of cells can be changed. This is what happens when you use this drug. Not that it will reverse anything, but it plays a role in changing a lot of these factors.
Okay, sir. Sir, in radiation-induced keratopathy or in dry eyes following radiation, what are the indications when we should use punctal plugs?
See, one of the things is, you as an oculoplasty surgeon could answer this, if there is changes in stenosis or if there's any major area, that is first thing we need to look at. But see, I'm not a very big fan of punctal plugs in inflammatory driven disorders because many times inflammation itself can create a change. So if you feel that it is a purely inflammatory disorders, then you'll have to probably treat them with anti-inflammatory and other drugs before you go ahead and put a plug, because putting a plug again causes a lot of cicatrizational changes which you don't need.
Okay, sir, as we expected major advances by this landmark year of 2020, what do you think are the downfalls that we are facing when it comes to the management of corneal diseases?
Uh, I feel the biggest downfall I am going to see is that mask-induced changes are going to create a lot of changes on your ocular surface. I did mention about it, and that's what I've been working also. Because when you wear a mask, what you're breathing out is carbon dioxide. Carbon dioxide causes hypercapnia and a lot of changes. Eventually, over time, carbon dioxide at a large thing is not good for the ocular surface. That I feel is one of the things. And lot of new lasers, new technologies, new diagnostics in corneal thing has been stopped because there's no trials happening. I was part of at least 2 or 3 different new laser machines trials, which completely has been stalled.
Okay, sir. And one more. Yeah, there is one question like when we are wearing the mask, there is dryness of the eyes. Is there any way to wear the mask in a different way or to use lubricants frequently to prevent that?
Or whatever it is, you have to wear the mask, and the best way to do is use the lubricant.
Yes, sir. There is last question, sir. It's on the artificial iris transplantation for cosmesis.
Uh, Artificial iris, is it?
Yes, sir.
I mean, it people did try, and it went into I think it's something banned by FDA also. I think that's something which you should just leave it uh, in your as one of your areas of interest, because People have become semi-blind or legally blind because of this. And I really think it should have been banned long time back.
Okay. Last question, sir. How to get into NN for Cornea Fellowship and Research?
If you have a passion, then you're welcome. We already, even in COVID time, I'm very proud that we are close to 10 fellows with me. I have taken 5 more than what I would take normally, because these are difficult times. Like I said, I always believe that in difficult times, you should not cut down, you should actually double it. And we are proud that we've still been able to train. Everybody is going to OT, and everybody is doing great research. So, like I said, to all of you, there is nothing called lockdown. There's a lot of fear among people that, what is going to be my career, what is going to happen. There's nothing is going to happen. And all institutes are going as it is. I'm sure Dr. Honavar sir is also doing as he was doing. Nobody is under lockdown for training or thing. If you have a passion, ask any one of us, and we are all driven by this. And you have seen a lot of work happening. Each and everything is not done by me. I mean, I'm just a brand ambassador to speak here, but everything is done by my people out back. And even now, if I go to my hospital, there'll be some fellows doing something or the other. So I'm just, if you have that drive, you should apply and be clear that you want to do. Because what happens is, the biggest challenge today is people are, you can't sugarcoat what you want. You have to be very clear of what you want. You want this, you want this. That's it.
Yes, sir. Thank you so much, sir. Hot sitters, you have any question? Saloni, Aziba, Soni, anyone?
They're silent today.
Done, sir, for the question part.
Thank you, Rohit, for a very nice talk and a very inspiring one at that. I think you covered a lot of points that would inspire postgraduates, and I hope some of them will be interested in research in cornea.
Thank you, sir. Thank you.
Good night.
Thank you, everybody.
Good night, sir.
Thank you, sir.